talking about a moment ago and dig a little bit deeper. Specifically, who should be screened and when?
Wonderful question again. I'm so glad I'm participating in this podcast today. So, every single woman, period, every single woman should be universally screened for substance use disorders, just like they should be universally screened for psychiatric disorders. And by screening, so it's interesting, right? When we talk about screening, we're talking about verbal or written screens. We're not talking about a what we call a urine drug screen, which is actually toxicology. So ACOG, American College of OBGYN, recommends that every woman is screened at least once during pregnancy for substance use. In my perfect world, we would do that at their initial OB visit, at least at that initial OB visit, because again, no greater motivation for change than when a woman is pregnant. So if we can catch her early, even if she declines any help or services, if we can identify her and keep offering offering either therapy or substance treatment or medications, even if she says no the first, second, or third time, maybe she'll say yes the fourth or fifth time. Even if she denies having a use disorder the initial time, if we screen again during pregnancy and screen again in postpartum, the more screening we do, the better that is. So
So,
when we look at screening options, the 4Ps or the 5Ps is an excellent screening tool that's recommended. The NIDA quick screen is also a good option, as is the craft for women less than 26. We usually recommend that. Any of those are wonderful screens that have been validated that are also recommended by ACOG.
so from what I understand, in a number of instances, pregnant women are fearful of having a screening because they're afraid of potential punitive measures. Would you say that these fears are warranted here in Florida?
Um, Another great question. So, here's what I tell pregnant women. So, when in the state of Florida, there's no reporting, if you will, of a woman using substances in pregnancy. The reporting does, however, happen. There's a CAPTA rule that means that a baby who is born exposed to substances having withdrawal type symptoms, that has to be reported. And it's usually reported to DCF or through social work to DCF. And that's usually done though after the baby's born. So when a woman's pregnant, that baby, if you will, doesn't have, I don't want to say doesn't have rights, but the baby doesn't necessarily count until it's delivered. Once it's delivered, then that's a substance exposed infant that is reported. So, what I usually tell women is this um, the best thing we can do is get you into treatment while you're pregnant, right? If we can illustrate that you're seeing a therapist, that you're going to AA or NA, that you're in treatment, that you're on medications, you are already taking all the right steps. And those give you the absolute best chances of keeping custody of your baby because you're illustrating that you're in treatment. So a woman who's in treatment many, many times is able to keep, the majority of the time is able to keep custody of her child. It's women who aren't in treatment or who are not doing well where DCF really may get involved.
And to follow what you said a few minutes ago, there's a large increase in the use of adulterated drugs, heroin. And if they are injecting them, then there's a lot of other adulterants that are going to baby's going to be exposed to. Does that rise to a different legal standard than if they're saying, I'm not simply taking pills? It's not good to just simply take pills either. But does it go to a different legal standard if you screen and find that they're doing IV narcotics?
So we do not typically report during pregnancy. We do not. And again, ACOG, the American College of OBGYN, it feels very strongly to what Dr. Schillinger mentioned, is that we do not want women who are pregnant to not attend prenatal care because of fear of being reported, fear of being arrested, or any of that. So ACOG feels very strongly that we do not report in pregnancy, and the rules really sort of follow that for us here in the state.
And just to follow up, and I think the screening element is mandatory, whichever particular form that is used. But if someone goes into treatment, and this is a big discussion, so I expect not a simple answer. Do you put these women on bufenirone? Do you put them on methadone? Do you detox them? What is, if there is a standard approach that's safe for the mother and for the baby? What happens?
Yes. So ASAM, the Society of Addiction Medicine, and ACOG, American College of OBGYN, both recommend that women are maintained on a long-acting medication such as methadone or buprenorphine for opioid use disorder in pregnancy. So the recommendation is that if they're on some short-acting, or if they're on fentanyl, or if they're IV injecting, whatever they're doing, that we transfer them over to either methadone or buprenorphine. My opinion is that whenever possible, I prefer buprenorphine to methadone. The reason for that is there are very good studies showing that babies exposed to buprenorphine versus methadone do better. So they require less treatment. They also have been shown to need less hospital stay related to treatment of NAS. The thing that's interesting about all of this is there's no specific dose of methadone or buprenorphine where if you're over this, your baby's going to have NAS, or if you're below it, your baby's going to be fine. So I could be on 120 milligrams of methadone and my baby only need to be in the hospital for 10 days, and you could be on 10 milligrams and your baby's in the hospital for 2 or 3 weeks. There's no rhyme or reason to it. It's just every baby and every pregnancy is different. And so the recommendation is that we have women on a sufficient dose of methadone or buprenorphine to prevent cravings and to prevent withdrawal. So if we can prevent cravings, that means that mom hopefully will not go out and IV inject, will not go out and prostitute to get more drugs, will not expose herself or the baby to other things like HIV, hepatitis, sexually transmitted infections, death, everything else. So for cravings, we want to make sure that she's on a sufficient dose to prevent cravings. The other thing is we want to prevent withdrawal symptoms. Now, there are some drugs, as you all know, that if somebody withdraws from, for example, alcohol, that they could die from withdrawal. Opioids are not one where a woman would die from opioid withdrawal. She'll be miserable, right? She'll have cramping, diarrhea, all sorts of things. But there is some evidence to show that that withdrawal could be dangerous or harmful to the baby. From withdrawal type symptoms in utero to the worst case scenario, which would be a fetal death in utero. So the reason that we choose the long-acting medications like buprenorphine or methadone are because they are long-acting. So they're much less likely to get a high and a low, the baby, like a peak and a trough, as they would with a short-acting medication like oxycodone or hydrocodone.
So, in terms of the goals during the pregnancy, you're saying it would be more leaning towards an MAT approach as opposed to a detox.
Yes, absolutely. Now, there are occasions where I will have patients who are very, very motivated to try to decrease their dose or come off of the medication completely. And so in those instances, again, it's not the norm, it's not the suggested route, but it is appropriate for some patients. For those patients, I recommend a slow taper